Good evening and welcome to First Say Chats by Dr. G. I'm Dr. Adana Grandison, a physician in Barbados and your hostess for this evening. First Aid Chats by Dr. G is a live podcast that provides listeners with a unique opportunity to not only hear complicated medical conditions explained, but also clarify any misunderstandings you may have about that condition. After all, a medically aware and educated patient is an empowered patient. This evening, our episode is entitled Our Precious Kidneys, and our guest is none other than Dr. Narissa Jarawan. Dr. Jarawan had completed her higher training in nephrology with the West Midlands Deanery in the United Kingdom and was awarded a specialty certificate in nephrology by the Royal College of Physicians, and then completed her certificate training in nephrology by the General Medical Council in the UK in 2016. Upon completion of her specialist training, she went on to work as a consultant nephrologist at the University Hospital Birmingham, a leading quaternary care hospital in the United Kingdom, having the largest transplant program in Europe. Dr. Jarawan has migrated to Barbados and has worked as a consultant nephrologist at the Queen Elizabeth Hospital for the last 3 years. She has specialized in all areas of nephrology, but has interest in the following areas: renal transplantation, working in conjunction with Dr. O'Shea and Dr. Bell to reestablish the renal transplant program in Barbados; chronic kidney disease unit on chronic kidney disease. Dr. Jarawan has participated in screening programs for chronic kidney disease in the United Kingdom and is currently implementing the KEEP, which is the Kidney Early Evaluation Program in Barbados. In addition, she also has interest in pregnancy, in chronic kidney disease, and transplantation. She's conducted specialty combined renal and obstetric clinics at the University Hospital Birmingham and is also an author on the topic in published nephrology texts. Renal vascular access. Dr. Jarawan is thoroughly trained and skilled in placing vascular access in hemodialysis patients and is an author of various texts in nephrology on this subject matter. Rare diseases. Dr. Jarawan was a leading developer of the tuberous sclerosis clinic at the Center for Rare Diseases at the University Hospital of Birmingham. Her research interests include chronic kidney disease, acute kidney injury, with a paper published in an international journal on mortality with acute kidney injury. Dr. Jarawan hopes that she can continue to contribute to the improvement of the quality of care given to the population suffering from kidney disease in the Caribbean and will continue to be an advocate for prevention, early detection, and treatment of renal disease and kidney transplantation. Good evening and welcome, Dr. Jarawan. Dr. Jarawan, can you please join us at this point in time by calling in? Good evening, Dr. Jarawan, and thank you so much for joining us this evening.
Good evening, Dr. Granson. Thank you so much for having me, and I'm delighted that we're going to talk about this very important topic. One thing I should let everyone know is that I'm a bit under the weather this evening, so I may stop a little to cough, but please forgive me.
Thank you so much. That's quite okay, Dr. Jarawan, and I hope you get better soon.
Thank you.
Dr. Jarawan, so before we go into the pathology associated with kidneys, tell us about our precious kidneys and how they normally function.
Okay, so I'm just going to take you through very simply. The kidneys are two bean-shaped organs, looking like, of course, the kidney bean, each about the size of a fist. They're located just below the rib cage, one on each side of your spine. Now, healthy kidneys filter about half a cup of blood every minute, removing waste and extra water from the body to make the urine. The urine then flows from the kidneys to the bladder through two thin tubes of muscle called ureters, and that's one on each side of the bladder. Your bladder then stores the urine, and the kidneys, the ureters, and the bladder are all part of your urinary tract. Now, what are the functions of the kidneys? So your kidneys remove waste and extra fluid from your body. Your kidneys also remove acid that is produced by the cells of your body and maintain a healthy balance of water, salts, and minerals such as sodium, calcium, phosphorus, potassium in your blood. Without this balance, your nerves, your muscles, and other tissues in your body may not work normally. Your kidneys also make hormones that help your blood pressure. So it's very important in blood pressure regulation, helps you make your red blood cells, and keeps your bones strong and healthy. So just to go into a little bit about how the kidney works very simply. So the functioning unit of the kidney is a nephron, and this essentially filters the blood and removes the waste products, passes it through the various tubules, and the urine is created. So that's essentially the function of the kidneys and how they work.
Great, excellent. So kidneys actually do quite a robust job in actually keeping a lot of things in check within our body, from electrolytes, waste products, even regulation of blood pressure. Now,
Yes.
I'm glad that you actually brought that up, because what exactly happens when the kidneys stop working as a result of chronic conditions, non-communicable chronic conditions, or hypertension or diabetes?
Right. So unfortunately, there are usually no symptoms of kidney disease in the
Mhm.
early stages. And I think it's important that we talk about the definitions of chronic kidney disease. So before we go on to the symptoms, just so that everyone understands. So basically, kidney disease can either be acute or it can be chronic. If you have any damage to your kidneys from whatever the cause, whether it is from a systemic condition such as diabetes, or from an intrinsic kidney disease, or from a genetic cause, you have kidney damage. And that's whether or not if the kidney function is normal, but you have structural damage to the kidney, and let's say through a genetic cause like polycystic kidney disease, then you are classified as having chronic kidney disease. Now, chronic kidney disease differs from acute kidney disease in that it is usually the damage lasts for more than 3 months. So that's how we know that it's a chronic problem. And there are many causes of the chronic kidney disease, but the most common causes, as you mentioned, Dr. Granson, are the non-communicable diseases, hypertension, and diabetes. Now, the way we classify chronic kidney disease is that we look at a marker in the blood called the creatinine. And we use this blood test. We put it into lots of fancy equations looking at your age, your ethnicity, your weight, what have you. And then we come up with what we call the EGFR, which is your estimated glomerular filtration rate, which is basically just a measure of how good the kidney is cleaning the blood. So the normal EGFR is over 90. And as you go down in the stages from stage 1 to 5, your EGFR decreases, meaning that your kidneys is not filtrating as much. So once you reach the stage of less than 15 mils per minute, then you have what is known as stage 5 chronic kidney disease. And that's when, as nephrologists, we tend to intervene, because by that stage you will need some form of renal replacement therapy. Now, the problem with the kidneys is that, as I mentioned earlier, unfortunately, in the early stages of chronic kidney disease, let's say stage 1 and 2, you do not really show any symptoms, and it may only be diagnosed if you have had a blood test or a urine test for another reason. In the more advanced stages, from stage 4 to 5, some of the symptoms include tiredness. You may get swollen ankles, feet, or hands. You may get a puffiness around the eyes. You may get short of breath. You may start to feel nauseous, vomit. You may just be very lethargic. And sometimes your urine may be frothy, or you can pick up some blood, or you may see blood in the urine. And your blood pressure may become very high. Unfortunately, again, these signs are only picked up later on in the disease process.
Okay. All right. So essentially, with early chronic kidney disease, we're essentially asymptomatic, which is quite interesting, because it would only be caught on constant testing or following up with your doctor, making sure you're going for your follow-ups. But can you tell us exactly why the kidneys become damaged with hypertension if it is that they're supposed to regulate hypertension? How does this really happen?
Right.
And
So with
similarly, I would ask the same thing for diabetes.
Okay.
Hmm.
So for the high blood pressure, basically it's a chicken and egg problem with the kidneys. So you can have another cause of your high blood pressure, or you can have what's known as essential hypertension, where we can't identify a cause. And this actually damages the kidneys. It puts a strain on the small blood vessels in the kidneys, and it can cause the kidneys to stop working adequately. And the opposite is true. When the kidneys aren't working well, you get a derangement in your sodium balance and all the hormones that are supposed to be produced to maintain your blood pressure, and that does not happen. So it goes into a bad state, and your blood pressure skyrockets. So it's on both ends. You can have kidney disease, which can cause your high blood pressure, or your high blood pressure, if not treated, can cause your kidney disease. Again, with diabetes, when there's too much glucose in the blood, if your diabetes isn't controlled, then that again it causes the kidneys to work harder, what we call hyperfiltration in the beginning, and the actual glucose molecules can damage the cells of the kidneys. And once this happens, it damages the nephrons, and your kidneys become damaged. Unfortunately, diabetes progresses. If it's not properly controlled, it damages the kidneys very quickly.
Hmm. Dr. Jarwan, exactly what percentage of the kidney has to be damaged before we would say some person has chronic kidney disease?
Right. So again, I go back to the way I explain it to my patients. I use the estimated glomerular filtration rate. So if we go back to that, I usually say stage 1 and 2, it's between over 90% is normal. Between 60 to 89%, if we work it out, and that's the EGFR that we come up with, then that again, you're damaged, but you're still okay. A moderate to severe reduction is between 30 to 44% and lower. So that is where we're actually going to start seeing signs and symptoms.
Right. So essentially, a very significant reduction in kidney
Yes.
function is actually when we start to get our signs and symptoms.
Yes.
So we shouldn't be comfortable saying, well, I don't have any of these signs and symptoms, so I may not have any problems with my kidneys. But you should essentially, especially for persons who have non-communicable diseases, certainly also check in their kidney function.
Yes, because that's a problem that is happening now, and not only in Barbados but across the globe. Because there are no early signs, by the time we pick up the chronic kidney disease, it's too late. We can't do anything about it, and all we can offer is renal replacement therapy and transplantation.
Hmm. Before we go any further, I see we have a question here from Paul G. Can damage to the kidneys be repaired?
The answer is yes. So, an acute kidney injury, which can be caused by a variety of factors, if you've lost, you're dehydrated, or you've taken certain drugs that are known to harm the kidneys. Again, if your cholesterol is high, sorry, your blood pressure is high, these are things that can cause acute damage to the kidneys. Usually, if the offending agent is removed, then your kidneys are very resilient and they recover. However, if it persists for more than 3 months, or let's say you just have an intrinsic kidney disease, something you were born with, and the kidneys are just being damaged, once it persists for more than 3 months, the chances of any reversibility, it diminishes. What we can do is actually slow the progression of the deterioration, but we cannot reverse it at that point.
Hmm. So you spoke just now about um, early screening. Can you tell us more about this early screening? And I saw also in your bio, we have that you actually you're trying to implement now the KEEP program. Tell us a bit more about early screening and the KEEP program.
Right. So early screening is essentially important. I can't stress how important this is because, to tackle this burden of chronic kidney disease, I firmly believe that we have to do it from both ends. We
Right.
have to attack it while it's still early so that we can identify the problem early and help to slow the progression of the chronic kidney disease. Since most of the chronic kidney disease is caused by high blood pressure and diabetes. So if we can slow those two down, then we can save a lot of people from going on to dialysis. Dialysis is the last measure that I would offer any patients. I would always prefer to prevent them from going on to dialysis so they can have as as much of a near normal life as possible. And the key is to pick this up very early. And because there are no symptoms until it's too late, we have to go there. We have to go out into the public and we have to screen. So any diabetic, any hypertensive, they should be screened for chronic kidney disease. And the thing about it, it's so easy to do. All you need is a blood test. All you need is a urine test. And then we can pick up if you have chronic kidney disease or any kidney disease. And when we look at the urine, there are markers in the urine, simple markers. We look at your if you have any blood, if you have any what we call red cell counts, any markers of kidney damage. And we can look at your glucose levels. And that tells us if you do have chronic kidney disease. We also look at the blood pressure. So these are very, very simple things that we look at, which makes screening so effective in chronic kidney disease rather than when we reach later down the line and we have to offer expensive therapies such as dialysis.
Right.
So
No,
what I have found is that we need to raise the awareness of this because people are not aware that they should be screened for chronic kidney disease. So they have to know that if you have diabetes, if you have high blood pressure, if you have a family relative with chronic kidney disease, because studies have shown that if you have a family member with chronic kidney disease, then you should be screened for chronic kidney disease. They need to know that all they have to do is just request a blood test from their doctor. And what we're trying to do now is implement this kidney early evaluation program, which is similar to what I conducted in the United Kingdom. And all it is simply a clinic where patients who would like to, not patients, persons who would like to see if they do have kidney disease can come in. We fill out a simple questionnaire. We check the blood pressure, check your blood glucose, check your blood tests, and then we look at the urine. And if we pick up anything, we let you know. If you do need a referral to Dr. Bell or myself, then it will be made. And we
great.
advise you of how you need to be monitored.
So very simple blood tests and a very simple urine test. And essentially, we look for any markers of damage, and if needed at that time, then a referral, early referral in, so that we can get on top of this very serious problem that we have. Up to today, actually, within the news, we actually saw Dr. Scanterbury making mention of the importance of actually and her concern as it relates to the alarming rates of diabetes and hypertension on the island, and the importance of transplantation and stuff like that. Dr. Jarwan, I know sometimes a lot of patients would come to me and say, Doc, I really don't want to take this medication because this medication actually damages the kidneys. And so a lot of persons are actually very resistant to actually complying with medications because of the concern that they have heard from persons in the community the medication actually makes the kidneys worse. Can you please lend some clarity to that?
Right. So, if, as I advise my patients, the only medications that I am worried about when you do have chronic kidney disease, and I advise all of my patients, are the NSAIDs. That's the group of drugs that you use if you're in pain. Drugs like diclofenac, ibuprofen, Baralgin, I think one is called Remetan. Those are the ones that if you use too much of and over a long time, it can damage the kidneys. Now, there are other drugs that can damage the kidneys. However, those drugs you may receive from a doctor or in the hospital setting, which is why it's imperative. And I always tell my patients, if you are going to any doctor besides myself or your general practitioner who already know that you have chronic kidney disease, you need to let them know that you do have chronic kidney disease, because there are certain drugs that they just need to stay away from. But by and large, it is not a whole host of drugs. So drugs are fairly safe. And what patients have to realize is that you don't stop taking a medication to control your high blood pressure or your diabetes because you think it's going to harm the kidneys. Because if those two things are uncontrolled, what you are essentially doing is damaging those kidneys. And yes, there is one drug which is quite beneficial to the kidneys, a class of drugs, the ACE inhibitors and the ARBs, and they're used for blood pressure control. They're also very useful to help your kidneys to stop leaking protein, which is the damage that occurs, especially with diabetes. And these drugs sometimes can make the kidney function a little worse. However, the overall benefit of it is far outweighs the risk. So I would say do not stop your medication. Certainly do not stop your medication until you discuss it with your doctor.
Great. We have another question here from Paul G. Persons with kidney disease are asked to be careful with the types of exercise that they undertake. Can you explain that?
Well, it depends again on the stage of chronic kidney disease. So certainly between stage 1 and 3, I don't advise any change in your exercise regime. At stages 4 to 5, in fact, exercise is beneficial. That is one of the ways of protecting your kidneys. Even if you walk for 20 minutes a day, that lowers your blood pressure, it helps everything. So I don't advise that you do not exercise. Stages 4 and 5, it depends on how you feel. If you're retaining fluid, if you're not as energetic as you would have normally be, then yes, you have restrictions to your exercise. I think what he may be alluding to is the hardcore exercise in terms of lifting weights and what have you. There have been some studies that persons that are very into weight training, what actually happens to the kidneys is that they become enlarged and they work a little harder, and sometimes that can cause kidney damage. But by and large, I will not say that patients with chronic kidney disease should not exercise.
Right. What about protein shakes and supplements that persons would use in the gym? Are those detrimental to the kidneys?
No, they're not. If you have normal kidney function, they are not. However, if you do have certain types of intrinsic chronic kidney disease, such as one of the glomerulonephritis, like one is called focal segmental glomerulosclerosis, then I usually watch the kidney function very closely. And sometimes those supplements, because they are packed with protein, they can make the kidney function a little worse.
Right.
But a normal person should not
have any challenges using their supplements?
Using the supplements, yeah.
Great. I have another question here from Sam. Doc, can developing lupus affect one's kidneys?
Yes, unfortunately. Lupus is one of the genetic diseases that has can have disastrous complications on the kidneys. So you can develop what's called lupus nephritis. And again, this is classified in stages. And what it essentially involves is that your body is producing antibodies that is attacking your body. And these antibodies attack your kidneys and cause inflammation. And if that inflammation is left unchecked and we do not treat it, then you get scarring of the kidneys and the kidneys stop working. So yes, it can.
Okay. You spoke earlier about the stages of kidney disease, 1 through 3 being relatively mild, and then 4 and 5 when we get even more concerned and really require specialist input. Tell us about the types of therapy that persons can have for having a presentation of chronic kidney disease, and how would you treat it?
Right. So I would start by let's start talking about treatments early on in the stage of chronic kidney disease. because I think that's very important. So between stage 1 and 3, your main treatments, and again, they're very simple measures: lifestyle changes to help you remain as healthy as possible. Stop smoking if you're a smoker. Start getting exercise if you don't exercise. Control your high blood pressure. Control your cholesterol. These are simple measures. Drink adequate fluids. Very simple to do. And please eat a healthy diet. I cannot stress the diet and the exercise. All of these conditions that cause chronic kidney disease are non-communicable diseases. And what we're seeing is that because the prevalence of obesity is increasing, obesity itself puts a strain on your kidneys. They have to work so much harder when you're obese, and that damages the kidneys. And I've seen it, and it's progressing very quickly. When you combine the obesity with the diabetes and the hypertension, it's mayhem on your kidneys. So these are the simple measures. Now, your diet, if you are hypertensive, if you are diabetic, please stick to your diets. Watch your sugar content. Take the advice of your doctors and your dietitians. Lower the salt intake of your diet. Some patients always ask me whether they should cut down on their protein intake. And I would say the studies have shown that there has been some benefit in cutting down on your protein intake. However, what I would advise is that you have to be very careful, because I do not want my patients to be malnourished. There is a very, very small benefit of it, and some studies have shown that there may be a benefit using plant protein as opposed to animal protein in terms of developing your blood becoming acidotic. There's a very small benefit, but again, I would say stages 1 to 3, you need a healthy, balanced diet. That is what you need, more than cutting down anything. So stages 4 to 5, when you reach stage 5, your kidney function is 15% and less. When you reach stage 10, that is where you require what we call renal replacement therapy. And all that means is that we have to give you some form of therapy to replace the job that your kidneys are doing. So there are 3 types of renal replacement therapy. There is dialysis, which is broken down into hemodialysis and peritoneal dialysis. Hemodialysis is a therapy where you come to hospital 3 times a week for 4 hours each session. It can either be hospital or it can be one of the satellite units, such as the Sills dialysis unit in Barbados. And we essentially have some way of accessing your blood, either through a catheter that is put into the neck, or what's called an arteriovenous fistula, which is created between an artery and a vein. This matures, or we use the catheter in the neck. We access your blood. The blood passes through a filter, very similar to a filter in a pool. It cleans the blood and it passes it back to you. So that's the first form, the hemodialysis. The second type is the peritoneal dialysis. And this one again involves placing a catheter into the tummy. And you are given a machine about the size of a microwave. We train you up how to use this machine. And essentially you're given bags of fluid which contain glucose at different strengths. And this machine, once you attach yourself to the machine, it puts the fluid in and out of the tummy, and that is how it cleans the blood. So usually this therapy is done at home and it's done while you sleep. So those are the 2 types of dialysis, and both are available in Barbados. So the third type, and by far the most superior type, is renal transplantation, which is why I am such a strong advocate of this form of renal replacement therapy. And I'll tell you why. This form of therapy, the renal transplantation, actually improves the survival of patients with end-stage renal disease. Hemodialysis doesn't do it. Peritoneal dialysis does it a little more than hemodialysis, but still not as good as renal transplantation. Renal transplantation gets a patient who has been feeling so unwell on either dialysis or peritoneal dialysis or hemodialysis back to an almost normal level of functioning and quality of life. So it's by far the most superior form of renal replacement therapy. And what it does involve is a surgery to have a new kidney either taken from someone who has decided to donate a kidney, somebody who's completely healthy, to donate a kidney to you once they are a match, or you can get a kidney from someone who has passed away, which is what is called a deceased donor. Currently in Barbados, we are reliant on live donors because we do not have the legislation in place for a deceased donor program, which is badly needed in Barbados.
Absolutely.
So, just a little bit about the donation. And I know lots of patients, lots of people listening may say, well, I don't want to, I don't want to donate a kidney. I don't know what's going to happen to me later on. How can I live with just one kidney? So, just to reassure you, with live donation, and I always tell everyone this, there's a reason God gave you two kidneys. That's so you can give to someone else because you are perfectly normal living with one kidney. And in addition, when you step forward to donate a kidney, we screen you from A to Z. If there's anything slightly wrong with you in terms of your health, then you are not eligible. And we will say to you, unfortunately, we found this and you cannot donate. So we only take kidneys from persons who have stepped forward who are completely healthy and who we know taking the kidney from that person is not going to affect them in any way.
Great.
Live donors, I mean, they, what I've seen in this field is that usually for live donation is usually a family member, a spouse or a mother to child. And the donors themselves actually derive such benefit from knowing that they have just saved their loved one's life.
Absolutely.
So it's, I want that point across that you will be perfectly fine after donating a kidney.
Dr. Jarwan, you spoke about diet. And I know that persons who have end-stage renal disease, they have some dietary limitations. Can you also tell us and share some of the dietary limitations or foods that they should stay away from if they have end-stage renal disease?
Okay, so with end-stage renal disease, what tends to happen is that you cannot control your salt, you can't control the electrolytes in your blood, and you can't get rid of your water because usually you don't pass as much urine as you did before, and you're reliant on these therapies to sort all of these out. So a lot of onus is on you to control what you eat because that's so important. So you have to have a fluid restriction, unfortunately. So patients that are on dialysis, they are usually restricted to between 750 to 1 liter of fluid for the day. So that's the first thing. They have to watch their salt intake because they can't get rid of the salt as normal people will. So they have to decrease their salt intake. They also have to look at their potassium because they can't get rid of potassium in the urine anymore. So they have to stay away from foods that are rich in potassium, such as potatoes, provisions, tomatoes, coffee, coconut water. When you are having the provisions and the potatoes and what, you need to boil them twice, what we call leaching, and that gets rid of the potassium. You also need to watch your phosphorus. So foods that are high in phosphorus include your dairy products, your egg yolks, your pastas, certain vegetables. So when you do have end-stage renal disease, you have to have a specified diet because you can't eat any and everything.
Right. We have another question. We're going to take another question here from Kenny. What are some risk factors that can lead to developing kidney stones? And I'm going to piggyback on that. And can recurrent kidney stones lead to chronic kidney damage?
Yeah, certainly. So that is a problem in Barbados that I have seen since I got here. So some of the risk factors are very simply, you're not drinking enough water. It's very important, especially in this climate, because it's so hot, that you drink adequate water, well, fluid in general, because it helps to flush out the urinary tract and thereby preventing stones. Some people are more prone to forming stones because one, they have a more acidic urine, or they tend to pass more minerals into the urine that cause stone formation, such as calcium, uric acid. So we actually have to do tests to see what type of urine they're passing, or if they do have stones, then we have to test the stones to see what type they are. And based on that, we can advise again with your diet and given certain medications to help prevent the stones from forming. But stones are a big problem, and yes, they can lead to chronic kidney disease because what happens with stones is that they can, if they get enlarged, they can block the kidneys and the kidneys can swell, a condition that we refer to as hydronephrosis. And what happens there is that just like if you block a pipe and you get the pressure building up higher up, the same thing happens in the kidneys, and that damages the kidneys. If it is left unchecked, then that becomes a chronic problem and we can't reverse it. And I will also make this point, this is a condition known as an obstructive uropathy.
Right.
And your prostate, it does it in a different way, but an enlarged prostate can also cause blockage to the kidneys. So for men, it's crucial that you check your prostate.
I am actually very happy you brought that up because we tend to find sometimes that men do not seek medical assistance professionally quite often. So I'm glad that you put in that plug again for men. I'm always trying to make sure that I encourage our guys out there to get themselves checked. I have another question. What prevents the pus from a perinephric abscess from reaching the contralateral side of a kidney?
Right. So both kidneys are in a capsule. So they are separate. So if you have, let's say, an abscess or pus in one kidney, it's not going to get to the next kidney unless the organism or the bacteria that's causing this pus is in the bloodstream and it goes into the other kidney and forms an abscess there. But the
Right.
kidneys are far apart and they're, encapsulated.
Great. So a person is diagnosed with chronic kidney disease. You stated that in terms of not just quality of life, but also the mortality associated with that person is not improved by a person. The is not improved by the person actually undertaking hemodialysis. Can you tell us approximately how long would we expect someone to live if they're on hemodialysis? And certainly in that, because we really don't want to get to that stage, but what do we want persons to know about chronic kidney disease in terms of how the livelihood that they would have after being diagnosed? And is all lost? Because you actually spoke about, very importantly, renal transplants. So tell us a bit about generally a person who's on hemodialysis versus a person who then goes on to have a renal transplant.
Okay, so people with chronic kidney disease, it's very variable. It depends again on the cause of the chronic kidney disease. Now, some patients may progress very rapidly, and as I said, we see that with the diabetics and with the hypertensives, especially if it's not controlled. And some people can, they lose their kidney function very slowly, even with chronic kidney disease. And these are usually the patients that take very good care of themselves and comply with everything. If it's a cause such as a genetic condition, or let's say the lupus that we can't treat adequately, then unfortunately you end up progressing quickly. So it's very, very variable. What studies have shown is that once you have chronic kidney disease, even if it's mild, you are at a higher risk of developing cardiovascular disease. You're at a higher risk of developing a heart attack or a stroke. And that is why it's so important to modify your lifestyle to help decrease, the risk of this happening. Now, when you have reached end-stage renal disease and you're on hemodialysis, again, this is very variable, but the survival of on hemodialysis is a lot less than when you're on transplantation. So if you're on dialysis, your 5-year survival rate, well, the mortality rate is actually now better since we have, we have better therapies, or we have refined the dialysis process. However, it's still not as good as if you have a renal transplant. And again, the leading killer of patients that are on dialysis is the cardiovascular disease, and that we haven't been able to change at all. In addition, when you're on dialysis, your quality of life is not as good as if you had a transplant. So you can imagine your day or your week going to a therapy, 3 times a week, 4 hours each time. Some people don't tolerate it. They feel, really drained out after the therapy. They can't, people, they can't work anymore because they're there all of the time, or they just feel so unwell. Again, what the dialysis is doing is just replacing what the kidneys do. They offer no benefit. They don't stop anything else that's going on with any other disease in the body. Whereas with transplantation, when you get that kidney, I've seen it. I've seen patients transformed. Their quality of life improves. They can go back to work. They feel better. They don't have all of these dietary restrictions, these time constrictions. Their social life is better. And they actually, although they still suffer from the cardiovascular disease, it's not as bad as if they were on the peritoneal dialysis or the hemodialysis, which is why we advocate that it is always better when you're diagnosed with end-stage renal disease or stage 4, which is close to the end stage, that if you can get a transplant at that time without having to go on to dialysis, that improves your survival. And the average length of time that a kidney can last after a transplant is between 10 to 20 years.
Right. Another question here we have from Yvette. Can kidney damage be completely avoided by controlling diabetes and hypertension?
The answer is unfortunately no. It cannot be completely avoided. However, if you control your diabetes and your high blood pressure, you prevent the deterioration. You slow it down. So let's say you're 30 something and you're diagnosed with diabetes and hypertension. If you do not control it, then your chance of ending up with end-stage renal disease is quite poor. You will be on dialysis, let's say within 2 to 5 years with no control. If you do control it, and you may live the rest of your life without needing dialysis. Right. So you can slow the progression of the chronic kidney disease. But unfortunately, you cannot. There is no way that you will not get damage.
Quite often, persons who have chronic kidney disease often complain of feeling very, very tired. Can you tell us what is the link between kidney disease and anemia?
Right. So your kidneys, they produce a substance called erythropoietin. And this is responsible, it's a hormone, and it's responsible for, it goes to the bone marrow and tells your bone marrow that it needs to produce red blood cells. So as the kidneys become damaged, certainly in stage 4 and 5, at stage 4, you don't produce as much of that. And at stage 5, you produce even less. So patients with stage 4 and 5, they don't produce this substance. And so they become anemic, meaning that their bone marrow doesn't produce as much red blood cells. And what a treatment for that is that we actually offer injections of this substance, erythropoietin, and that raises their blood count. So that is why they feel so tired.
Mm-hmm. In terms of you spoke very nicely about the diet and how we really shouldn't modify the diet too much, especially in the early stages. But then certainly with persons who have end-stage disease, they should be monitoring certain things that actually can distort the electrolyte concentrations that we have within the body and cause further problems.
Mm-hmm.
We spoke quite nicely about the drugs, especially NSAIDs, that persons who have chronic kidney disease should definitely stay away from because those actually damage the kidneys more. Are there any herbs or bushes that really we should stay away from, or do you even recommend that people even use them at all?
Yeah, that's a very good question. So there are herbs that can affect the kidney function, and so because I don't know every country you go to, there are herbs indigenous to that country.
Right.
So I can't tell you for sure, especially in Barbados, I don't know as yet which ones do it, but I always advise to stay away from unknown herbal supplements because you don't know what is going to do not only to the kidneys but also to the liver.
Mm-hmm. Mm-hmm. Is kidney disease worse in children or in adults, or is there any difference?
So usually in children it's a genetic disease. So
Right.
I would say that it is usually a little worse depending on the type of disease. Because it's a genetic condition. Some children are born with just one kidney, or they're born with kidneys that are too small, or they have certain problems with their urinary tract and they're prone to infections and what have you. But with adults, I would say that what we're seeing is that it is more severe, and that is because one, the proportion of children that have chronic kidney disease is a lot less than adults that have chronic kidney disease. And two, with the adults, it's again because of lifestyle.
Right.
So the majority of chronic kidney disease that I'm seeing in adults is fully preventable. So I would still say yes, it is more severe in a child because that's a genetic condition that they can't do anything about. But often, most times in adults, the adults can do something about it. They're just not doing what they're supposed to be doing.
I noticed the fact that you spoke earlier about the family presence of chronic kidney disease. How early should an offspring be screened to see if they actually have kidney damage?
Right,
And,
depends on.
and what age should they start at?
Okay, so if it is that it depends on what the family condition is. If you know that you do have a genetic condition in the family, like let's say polycystic kidney disease, which is it's passed down in a dominant fashion. So we know by the age of 18 to 21, we have to screen patients for it, the family members, to see if they have it. If it's nothing like that and it's just your family relative has had chronic kidney disease due to diabetes or hypertension, then the normal age would be about 21.
Right. And how often should they screen?
They should screen once the kidney function is fine, I would say every 2 years. But if they are developing symptoms, or if they notice their blood pressure is going off, or they have some bit of protein in the urine, or they have blood in the urine, or glucose in the urine, then they should be screened every 3 to 6 months. That's with a blood test, and that's with repeated tests to see what is going on, because that tells you that something is going on there and you need to pick it up and treat whatever it is.
Okay, so our final and last question that before we start to wrap up this evening, I'm going to go back to those persons because I know with the COVID lockdown, a lot of us, we were at home. We probably weren't eating as nicely as we should. And we had reopening of the country, and a lot of persons are now hitting the gym very feverishly. Any warnings in terms of excessive exercise and the possibility of rhabdo? What do you have to say about that?
So, what I would say is that rhabdomyolysis is a condition where you get a lot of muscle breakdown and you get this substance creatinine kinase that actually clogs up the kidneys and it causes acute kidney injury. Now, from what I've seen in working in Barbados is that it seems to be a little more prevalent than I thought. So I would advise that, you exercise sensibly. If you know you're exercising and you are developing cramps, especially in the legs, or you're exercising and you're not hydrating adequately, or you're exercising and your urine becomes a different color, blood tinged, then you are probably going to develop rhabdomyolysis. And so I would advise that you do not overdo it, and again, exercise sensibly. Don't overdo it.
Right. And
And
certainly,
ensure that it's adequate hydration and that you know your body. If you're doing something and you notice that there's a change, then stop and seek some form of medical attention so that we can check and see exactly what's happening. Because that is a cause of acute kidney injury that is fully reversible.
absolutely great. So, Dr. Jarwan, any take-home points, especially you spoke about our KEEP program, which is underway in Barbados, which I think is an excellent program, and really everyone should take the opportunity, whether having a family history or not, because we have such a high rate of hypertension and diabetes, and almost every single person that you know, whether in your family, outside of your family, actually has hypertension or diabetes or both. And so any final take-home points for that, as well as transplantation, renal transplantation, which is something that certainly can significantly change the lives of persons who may have end-stage renal disease?
Yeah, so what I would say is that, I am so happy that we are going to embark upon this screening program, because I can't tell you how much chronic kidney disease is out there. I know there's a lot of diabetes, I know there's a lot of high blood pressure, but I don't know the true figures that we have for chronic kidney disease. And it is frightening, because I am sure what we are seeing in hospital is just the tip of the iceberg.
Right.
And again, I'm going to make this point. Chronic kidney disease does not have to lead to end-stage renal disease. If we pick it up early, meaning if you want to come and get screened, please do come and participate. If we pick it up early, we can delay the process and prevent you from ending up in end-stage renal disease, and you can lead a fairly normal life. So that's the first point. So our screening, Dr. Lambert from the Sills Dialysis Unit has actually combined with us at the hospital, Dr. Bell and myself, and he is carrying out screening at his clinic at the Sills Dialysis Unit. So I can give you the details, and anyone that's interested in starting that, they can start.
So this is already happening here.
That has already started to happen as of last week. Now, the other part of the screening is where we have liaised with the Diabetic Association, and we hope to actually go into the parishes with a mobile unit and invite patients. We are on your doorstep. You just come to us and you get screened. You don't have to go anywhere. We are coming to you. But because of the coronavirus pandemic, we have been unable to start, and we hope to do this next year. So, a lot of patients, and I will say this, they are afraid to get a diagnosis of chronic kidney disease, but it is so important. And as you rightly said, even if you don't have a family member with chronic kidney disease, but you have diabetes, you have high blood pressure, you have prostate problems, you have stones, come and get screened, and let's see where you're at and how best we can help you to have a normal life, because we do not want you to progress to end-stage renal disease and develop all of the complication that comes along with that. Because, once you reach that stage, you are not going to have a healthy life or a good quality of life. And that will lead me to my other point, which is at that stage, the best form of renal replacement therapy for you will be a kidney transplant. So it's important that you prevent that from happening.
Certainly.
And the onus is, we are here to, we're here to do the best that we can for you, but we need you to step forward. We need you to step forward to come for screening. We need you to step forward as donors. We need your voice to be heard for, making a case for deceased donation in Barbados, because we need all of this.
Great. So prevention is certainly better than cure as it relates to our precious kidneys. And certainly I'm very, very happy that you took this opportunity, even though you were a bit under the weather, Dr. Jarwan, to really come out and educate the public, certainly about chronic kidney disease, especially, and the fact that, there are options available, and that we have already commenced that KEEP program, which is an early screening program that we have locally on the island. If you are interested, Dr. Jarwan, she's going to post it in the message blog. Please take advantage of it. It's a simple blood test, a simple urine test, and then, if needed, referral where you can get the care that you need. Let's attack this early before end-stage renal disease. I want to thank you so much, Dr. Jarwan, this evening again for coming. And to my listeners, I want to say thank you for all of those who have actually messaged in. We didn't have any callers this evening, but that's okay. I know that the majority of you were listening quite attentively as Dr. Jarwan actually provided information this evening. And I want to say, join us next week, same time, same place, on First Aid Chats, Closing the Gap. Thank you, and good evening, Dr. Jarwan.
Okay,
good evening, everybody.
Thank you very much, Dr. Cranston, and good evening to everyone.
Bye-bye.
Bye-bye.